This coming Thursday, patients with brain injuries and their families will be testifying in Albany, calling on lawmakers to make sure they are protected. Among those expected to testify this week, one Western New York teenager looking to use his experience to make an impact on everyone here in New York. 7 Eyewitness News reporter Sierra Johnson has his story tonight.
Active, animated, and athletic, Joey Fisher is like any other 16-year-old. Tonight, we found him at a basketball tryout, a far cry from where he was just 2 years ago.
And they said, we think he got his bell rung, is what they call it.
All I remember is I was on the ground, people were asking me questions, and then I was in the hospital.
While playing in a league football game, Joey sustained a hit and then an accidental kick to the head. The force gave him a concussion.
Pain, confusion, dizziness, I puked. It was just a lot happening at once.
Joey was immediately hospitalized, but it didn't take long for his mother, a nurse, to realize this concussion was different. Her 16-year-old son was unable to walk or read for nearly a month after that game. He ultimately had to take a year off of school, and his mother quit her job to care for her son. After months of rehab and physical therapy, Joey is back in the game, and now he's going to share his struggle with the New York State Assembly.
It's about what we can do to provide services for families and for those after the fact.
Assemblyman Mickey Kearns will introduce Joey, who will be the first of 65 concussion sufferers to tell his story to state lawmakers. Several committees will be at the hearing to gain a better understanding of the causes and effects as lawmakers work to finalize treatment guidelines for traumatic brain injuries.
We want to advocate for more coverage for people with mild head injuries.
Joey and his family hope this 10-minute testimony will have a positive impact on how hundreds of thousands of New Yorkers living with concussions are cared for.
Colleagues, it's an honor to be here today. This past Sunday, it was very sad in Richard Park, New York. The Buffalo Bills were playing the New York Jets, and unfortunately, my beloved Bills lost. But something happened after that game. And something that you hear during many NFL games, you hear the term concussion protocol. Carlos Williams, a star running back, suffered a concussion. We're sure that Carlos received the best care as a professional football player. And we know today, even down to the high school level, that protocols have changed to address prevention and also the type of tackling that many players face. Joe Fisher came here from Buffalo, New York, as a high school athlete. Unfortunately, Joseph suffered a concussion. It put a tremendous amount of pressure and stress on his family. The Fisher family, 6 good Irish Catholic young kids and 2 good Irish Catholic parents. Unfortunately, Mom, being a nurse in this situation, had to quit her job. Even being in the medical field, understanding TBI was very difficult for her. So today, I'm here to introduce Joseph, who has suffered greatly. Mom had to quit her job, and for 1 year, they have suffered financially by the family having to then go on Medicaid insurance. This is something that hopefully we will address today. Changes not only at some of the highest levels, but I think all of our athletes need, and these concerns need to be addressed. One example is just the treatment plans and case orders that are available to the parents and families of TBI patients in the emergency room immediately following the injury. They were very nervous and scared and didn't know who to answer one question. So thank you, this honorable committee, for addressing this very important issue. And I'll let Mr. Fisher, Joseph Fisher, who is a sophomore at City Honors High School, sophomore. You look very distinguished today, so. One of our most prominent schools is Buffalo, New York. So Joseph, I'm here to introduce you, and if you'd like to tell your story to the committee, we greatly appreciate it.
Hi, I'm Joe Fisher. I suffered a concussion November 2nd, 2013. I got hit helmet to helmet. He came straight on me, and I hit the back of my head on the ground. Then I got kicked from the side of the head by a cornerback who was popping the play. All I can remember from that day is I was on the ground, people flashing light in my eye, stare at the ceiling. I had this little sticky toy that I could throw at the ceiling. I didn't start physical therapy until I think it was December. Then he gave Ryan physical therapist. He got me to walk. He helped me tremendously. I would not be where I am now if it wasn't for him. I probably still suffering from migraines, and every day it was migraine. Every single day I was busy at migraines. I took a lot of medicine. I couldn't sleep. I would get up until 6 a.m. I'd fall asleep then, and I'd get up at 8 a.m. to go to the doctor's appointment or a chiropractor or physical therapy. And like you said, my mom, she had to quit a job just waking up to make sure that I didn't take my medicine. So that was hard. I missed a whole school year. I had to go on what is home instruction, and I had teachers come to my house and try to work with me for the amount of time that I could. I could only do, it started out like 5 minutes of work, and then it eventually got to like an hour to 2 hours. And I was just working to try to be able to take my readings today. So that was really all I could do. And I'd be really tired after the sleep because I closed my eyes and I had to be pounding. So then finally, I eventually started to get out again after all the physical therapy and everything. I did physical therapy for 2 years. I just ended recently. And so then now, thank God I'm back from basketball and some of the sports that I was, but I am never allowed to play ball again. I might be able to play soccer again. I love hockey or lacrosse, and I love those sports. And I just recently got off my medication for my head, which is good. So, thank you.
So just wanted to say one more fact on it, and one of the reasons why we came here, Joe has been an advocate and spokesman. The school is putting together a year-long project to highlight this and to give other support to other people who have supported, especially young people. TBI, want to talk about that a little bit, Joe? Just your advocacy for your school.
Oh yeah, I'm doing a personal project, and I'm trying to spread concussion awareness so that people know how serious concussions are. You cannot go to this alone, and you need some professional help. I'm trying to make a documentary so that people know how serious they are, the after effects of when, like, one person needs to feel whatever, how long the recovery actually is, how painful and tragic it is on family. And so I'm doing a documentary to try to show people how serious concussions are.
Thank you.
142,000 New Yorkers were treated in emergency rooms for traumatic brain injuries in 2012. That's the most recent figure available. How their ongoing care is paid for is an emotionally charged issue, drawing a large crowd to a hearing in Albany today. It surrounds New York's Medicaid waivers that help people with traumatic brain injuries get care at home.
And then for the first month of recovery, I couldn't walk.
Joseph Fisher, a high school sophomore, traveled from his Buffalo home to talk to lawmakers today. He wants them to understand how important quality care in the community is for people who suffer brain injuries, and not to change how those programs are paid for. He's one of the many people who suffer a TBI, traumatic brain injury, every day in New York. His stemmed from a concussion on the football field. More often, TBIs happen from falls and accidents affecting people of all ages. So
my name is Jake McPherson, for those of you who haven't crossed paths with. I'm a physical therapist. A little bit about my background. I graduated from UB. I earned a bachelor's degree from UB. I'm board certified in neurologic rehab. I've got a certification through Emory University in vestibular rehab, and I also work a lot with individuals who have MS and credentialed through one of their MS organizations. But the point of today's talk is talking about vestibular therapy and specifically dizziness and imbalance, and some talk about headaches that people will experience after concussion. So what's a concussion? So a nice simplified definition is any trauma to the brain caused by blow or bump to the head, causing movement of the brain's head to skull. So leading causes, this is from the CDC, related to emergency room visits. So the number one is falls, then currently unknown, and individuals who are either struck by something or up against something, and then followed by motor vehicle accidents. So as far as what actually happens when somebody does sustain a concussion, we're talking about injuries at the actual level of the neuron. So our brain is made up of about 100 billion brain cells. Those brain cells are called neurons. So they sort of show in this picture here what those nerve cells look like, and they're pretty long generally. And because of that, they're susceptible to different kinds of forces. You can have shearing forces where when the head moves in one direction, that nerve is stretched, or it can be compressed, or it can be twisted. All of those different forces result in some kind of damage to that cell tissue. And then if you multiply that by how many cells are involved, that can sort of dictate how severe the injury actually is. So when you do have an injury like this, what's actually happening inside of the brain? So things sort of happen in sort of a sequence after a concussion. So when you have damage to these individual nerve cells or these axons, you get a little opening. So things stretch and there's a little gap, and then certain things that are supposed to remain inside the cell start flowing out, and then certain things that are supposed to be outside the cell start rushing in, and then it sets off this kind of chain reaction. So we have mechanisms that are supposed to maintain that balance inside of the cell, and when things start going all haywire like that, it needs to work really, really hard to try and reverse that. That's a very energy-consuming process. At the same time, there's some other things going on that actually reduce how much energy is being delivered to the cell. So on one hand, you've got this process that requires a lot of help, a lot of energy, and on the other hand, you've got something that is actually slowing down how much energy is available to the cell to help reverse that process. So that's where some of the damage comes from. If it's not able to accomplish what it needs to do, you do eventually get some damage. The symptoms of concussion, a lot of people either break the different symptom categories into 4 or 5. So you've got physical symptoms, which are more the ones that people feel that are pain or dizzy or equilibrium related. You've got cognitive symptoms, emotional, and then things related to sleep. Some people will then further break down the physical category into headaches and then equilibrium, balance, and dizzy issues, making up the 5. So it's very common for individuals to present with sort of different combinations of this whole big list of symptoms. Some people have a lot of headaches, but they're not having trouble sleeping, or they're having a lot of trouble sleeping and they're very dizzy, but cognitively they're doing fairly well. It's sort of a mixture of these different types of symptoms depending on the individual. As far as what sends people in through our doors, it's more of the physical symptoms. So the headaches, the nausea, the vomiting, also the vomiting, but balance, dizzy issues, problems with vision, whether it's eye strain with reading or difficulty working with monitors. I did tint all of these slides gray. Sometimes the contrast is like really bright when it's black writing on the white screen. So it might throw off some of the pictures, but we'll see if we do. But anyway, these are kind of more of the symptoms that bring people in for vestibular therapy or physical therapy. I want to go through and talk about different symptoms that people will experience between dizziness and balance and headache-related things. So we're going to start more with dizziness. One of the complicated pieces of working with individuals who are dizzy is dizziness is a purely subjective symptom. You can't really measure someone's dizziness or, for the most part, watch their dizziness or quantify it in any other way. So you're always depending on how does something make someone feel. How do they describe this feeling that they're having? And that description is very different. Two people can be experiencing the exact same thing, and they will come with 2 different stories about what triggers it, what causes it, what does it feel like to you. And the important part is the way that somebody feels their dizziness, the individual characteristics of it. They let you know how to treat that person, kind of what is their primary issue. Is it more of a visual thing where they get really overstimulated when they're looking at complicated backgrounds? Or are they more lightheaded when they have to get up quickly when they've been sitting down for a while? And these little clues that people give you while you're talking to them help you kind of put everything together as far as what their actual dysfunction may be. And then you take that, and that's how you move forward with treating. So these are just some different things that they say when they are experiencing dizziness, and then it's kind of so what is vestibular therapy? Some people, the first question they say is, it's nice to meet you, but what is this? What's going on here? What's vestibular therapy? Never heard that word before. So vestibular refers to the inner ear, but vestibular therapy itself is much more broad than that. A pretty basic definition of vestibular therapy, at least with what we do, is sort of the comprehensive overview of how your body maintains equilibrium. So the idea of balance and dizziness, and then the different systems that help us do that. So we have different systems that help us maintain our equilibrium, and it's up to all of those systems working together, and they're all kind of coordinated by some of the processing areas within our brain in order to make sure that we're kind of acting appropriately or able to control our balance and not be dizzy in different environments. So the main systems that we use for our balance, number one is our vision. That's kind of the one that we rely on as humans the most. I can look at you guys right now and see that I'm not moving because I can see that you're not moving. When we're in different situations, we relate how we are, how things in our environment are, and that's sort of how we reference ourselves in relation to them. You also have your vestibular system, which is housed inside of your inner ear. So our inner ear organs are picking up on position changes when we're moving our head, or if we're moving our body, or if we're in an elevator and it lifts up, or if we're in a car and it speeds up. Our inner ear organs pick up on that kind of information. We get feedback from our feet and ankles, so we get little motion sensors, and they call them proprioceptors, that sit in the soles of your feet and also in your ankles, and that gives your brain information about where you are in space. We also get some feedback from your neck, again, about this sort of position awareness, and we'll talk a little bit about that. But the big important piece in the middle there is the brain. So you've got these sort of symptoms on the outside, systems on the outside, that are giving us information about where we are, but ultimately it's up to the brain to decipher all that information that it's getting. I want to break these things down kind of one at a time. So we talk about vision, and then you've got the inner ear organs, and then things you get to the ground from your feet, and then your neck. So if you think about balance and equilibrium as sort of a pyramid, vision is sort of at the base. We, like I said, we are very dependent upon our vision for balance. We know that people who have visual impairments early on after a head injury, statistically it's going to take them most of the time a little bit longer to get better from their concussions than other people who may not experience that early on. Concussion may result in impaired control or movement of the eyes. So our eyes have a lot of different functions. They move. The movement of the eyes is very complicated in the way that they decipher images and transmit them back to the brain is very complicated. I think it's up to 65 or 70% of the brain is responsible for some type of visual function, whether it's visual memory or moving your eyes or helping with recognition of images. So vision is a huge part of really the function of our brain. So just a few basic movements of the eyes that we will almost always examine when we're seeing somebody. I just picked a few of sort of the introductory ones. The ability to have a smooth pursuit, so this is using your eyes to track something that's moving at a relatively slow speed. So if I drag my finger across, or I'm standing at a crosswalk and I'm watching a car move and my head is still, I'm kind of following it as it drives across me. That's more of the ability to take your two eyes, have them follow a target and move smoothly together as that goes from one position to another. Another eye movement that is a much faster eye movement is called a saccade or a saccade, and that is taking your eyes and quickly looking from the light switch in the back of the room to somebody here tonight. So it's a quick eye move from one target to another target, and you can see the target you're starting from, and you already have an idea of where that other target is, and your eyes go very quickly to the other target. That's actually one of the fastest muscle contractions that our body is able to produce. Is that movement from one thing to another really quickly. Convergence is probably the most frequently altered eye movement that I see. So convergence is the ability to focus your eyes from something that's more distant and then bring your eyes together and look at something more close. So if I hold my finger out here like this, and then I bring my finger in toward me. My eyes almost cross as that object is getting closer. And in order for you to have a good view of that, your eyes have to work together to be able to sort of point at that. So if it's way out there, my eyes can stay pretty far away, but if I'm looking at something way up here, my eyes have to come in like this, and then both eyes kind of point to the object, and you have a good idea what they're looking at. For some people, when I'm actually looking at this, what'll end up happening is I'll have my finger way up here, and it's coming in, it looks pretty good, pretty good, pretty good. And then all of a sudden, one eye keeps moving in like it's supposed to, and the other one sort of stalls out. So then as soon as that starts to happen, they say, no, it looks like a double. So if those eyes aren't working well together to point at the same object, if one comes in like normal, and the other one lags behind a little bit, their eyes end up missing that target, and that's what makes it look more blurred or doubled. And we actually measure that distance, and that should get better over time with therapy. This is huge with people when they're trying to read. If your eyes can't come together to focus on words on a page, and then use that more quick eye movement where your eyes are rapidly going from one word to the next, and then the end of one line to the start of the next line, if there's any inaccuracy with those eye movements, very hard to read. And then your eyes, your brain sort of has to work a lot harder to figure out, okay, why isn't this working? And then your eye muscles are working harder, and then all of a sudden you get this strained feeling. And for some people that evolves into a headache. The reason I bring up more of these more basic eye movements, if you're having issues and these sort of foundational eye functions are not working well, it's very hard to move forward and work on other high-level activities. So sometimes people will be working on different kinds of balance or vestibular exercises, and they're very challenging, and they're not getting better with them. When you sit them down, you start more with some of the foundational movements, you can tell there's issues from the base. They're already having trouble down there, so you need to pull way back with all the things they're doing and start from the most basic level so they can improve with those things. So when you're talking about these sort of individual visual functions, like, it's nice to be able to follow someone's finger when they're showing it to you, or, look between the two targets. But what ultimately you need to be able to do is have the ability to perform those functions in a real life environment, which is something that we end up looking at. So it's nice in the beginning of therapy if we understand that some of the more foundational pieces are working, but then we'll make you stand, and if you're a hockey player, you need to look down at the ice and then up at the puck and then to the next guy, performing those different eye functions in a quick manner to make sure that you're able to do it at the speed that you need to for whatever it might be that you're working on. Sometimes when people bump or hit their head or have a jarring motion, these little crystals that are supposed to be in one area of the inner ear organ become dislodged into another area, and it creates a fairly severe dizziness. That happens. That happens about 5% of the time when somebody is experiencing or has experienced a head injury. The nice thing about this is it's purely mechanical. So these little crystals that you can see here, they live in this area of the inner ear organ right here, which is kind of this plump part right there. They sit on these really sticky layers, and those layers are actually sensors, and they're what makes us sensitive to moving up and down and forward and back, more gravity-influenced movement. If you do hit your head or strike something like that, then those can be dislodged, and it creates a very predictable kind of dizziness. When you lie down, you get dizzy. When you roll over in bed, you get dizzy. If you look up for a while, you might get dizzy, or you're bending over to look underneath the car, you might get dizzy. It's pretty brief. It rarely lasts more than 30 seconds, and it's usually even shorter than that. And it's almost always a room-spinning dizziness. So it's not just a little bit of lightheadedness or you feel a little woozy or nausea. It is very intense, and then as quickly as it came on, it goes away, and afterwards you don't generally have too many residual issues, although it is possible. The treatment for that is depending on which one of these three little canals here that you can see those crystals get stuck in. The treatment becomes just a little bit different, but it's basically a rolling maneuver, where once you've identified which canal that it's in, you take someone through a different movement sequence, and that's supposed to sort of send them around the hoop back to where they came from. So that's something that's very specific to the inner ear. Another thing that you can have that Dr. Zhang has also mentioned is something that they call a labyrinthine or inner ear concussion. So we have our inner ear organ, which is embedded in our inside of the bone near our ear. So this is your ear up here. You've got the ear canal where you put a Q-tip, and this little web thing there, that's your eardrum. Most of the stuff on the other side of that is considered your inner ear. So the thing that looks like a snail right here, that's your cochlea for hearing. And then this, the rest of this right there, that's more of your vestibular system. So this area in the middle here is where those little crystals live, and then again, these are those three canals, 1, 2, and 3. All of this is actually embedded within bone. So there's bone with kind of like some channels and a little cavern in it, and that's where these organs sit. If somebody hits their head or they're exposed to a very large force, it's almost like it shakes that area. As a result of that, you can have damage to how that area is able to function. One of the more common ways that you have damage is with this nerve right here. So this nerve comes, part of it goes toward the cochlea for hearing, and the other two pieces go to the vestibular system for balance and equilibrium. That nerve travels back to the brain through a very, very narrow canal. If something happens in this area and there is swelling in there, it's very common for that nerve to just get pinched off. So you can kind of see this reddened area here, where that compression actually causes damage. And that's a peripheral inner ear problem. That's not necessarily related to the actual brain and the concussion with this changes in the cells and all the things that we had talked about in the beginning. And that is something that we can test for, and I would say that it is one of the less common reasons for being dizzy after a concussion. It's actually more common to have an ear infection that does that to you. So anyway, the result of that inner ear concussion, the labyrinthine concussion, is treated a little bit differently than some of the other things that people may present with. And that in the very beginning will cause a pretty severe dizziness that can last anywhere from about a day to a week, where you have like extreme dizziness, and then as that subsides, you're more sensitive to movement, and your eye movements will be off by a little bit with certain positions that you have your eyes in, and that slowly subsides, and then there are some basic vestibular exercises that will help you get over that. The vestibulo-ocular reflex, so it sounds really complicated and this drawing is a little bit much, but all that really means is that when you want to, you can move your head and keep your eyes stable on a target. So if I want to look at my thumb and turn my head real quick and have my eyes still be looking at that, so I'm having a conversation but I need to look away and keep my eyes on the person who's talking to me, that is a reflex that's actually mediated through your inner ear vestibular organs. That's one of the most important functions that they serve. So when you do that, you look at something and you move your head, it's not just like your eyes stay still on that target while your head moves. When your head moves one direction, in order to remain fixated on that target, your eyes have to actually move the opposite direction that your head is going in order to have your gaze be stable on that one object. So what ends up happening is you turn your head to one side, that inner ear organ gets excited, tells your brain to tell your eyes, hey, if you want to keep looking at this thing, you better get over that really quick. So, and it happens instantaneously through a bunch of different nerve connections through the brain and back. So this is really important in retraining certain kinds of dizziness. This is sort of one of the oldest exercises out there in vestibular therapy, is looking at a target and shaking your head no at it or shaking your head yes at it. That is a very important function for us to have, but I think sometimes it's a little bit overused as a treatment, and if you have other things going on, it'll actually make you feel considerably worse. And sometimes we do make people a little bit dizzy, but it's in the name of making you less dizzy, whereas sometimes if you're performing this activity, you can actually feel a little bit worse unless it's under the right circumstances. So we talked about vision and the inner ear a little bit. So the main conductor for this whole thing is some of the balance processing areas in your brain. If you look at this big nasty thing with all the lines on it here, this is your brainstem. So your brainstem sits right at the base of your brain. So your spinal cord comes in, and then this kind of highlighted green area, that's mostly your brainstem right there. If you think about some of these sort of shearing and compressive and twisting forces that happen when your head and brain are subjected to these forces, this area right here is extremely vulnerable. A lot of the twisting, so if I have my brain up here and this is sort of my brainstem, when my head hits, the whip or the twist ends up happening a lot of the times right through that brainstem area. The neurons that are traveling through there, they're carrying some of our visual function. They're carrying the feedback that comes from our inner ears and going back to our brain. They're carrying that information from my feet that is telling me sort of, all right, where am I in space right now? So if the neurons that are carrying that information are disrupted, or the neurons that are going back down through the system are disrupted, that's where you're going to get a lot of these balance, dizziness, equilibrium symptoms. The nerves that go to your eyes that help them move, they come from this area. So that's a very common reason for people to have difficulties with some of these eye movements that I was talking about. You know, when you're shaking your head like this and you're trying to keep your eyes on one thing, that inner ear organ is sending its messages partly through there and then it has to come back through in order to make your eyes behave appropriately. So I always tell people this is kind of like the computer that's processing all of this stuff. So maybe your eyes are working great, you know, you can see perfect, your eyes, they move all right, and you've got really good inner ear function, you know, your inner ear organs are doing their job. If, as a result of this concussion, this processing area is impacted, it's going to throw off how you function overall. The question becomes, how do we treat some of these balance and visual issues? The visual things are more specific to what somebody's presenting with. So like I said, one of the more common things that we see are this idea of convergence insufficiency, where they're not able to move their eyes inward together. That's kind of a different movement for our eyes than most of the other ones because they're sort of working opposite each other. They're coming in instead of both going in the same direction. There are exercises that are pretty basic for that, starting from just following your finger in like this until it doubles and then coming back out. That's kind of one of the old ones that we still use today, and they work fairly well. If that's not working well for someone, then we sort of just keep progressing down the line. Sort of varied intensity from looking at something real close and then quickly fixating to something farther away, or looking at an object on a clear sheet and focusing on something at a distance and coming back. They make these things, they're called Brock's strings, where it's a string with a bunch of beads on it, and you tie one into a door and you follow the different beads with your eyes, kind of practicing making those two eyes work together to go from a far target into a close target and back, so that when you are trying to do things like reading, your eyes are able to point at the same thing and you can see clearly without blurred or double vision. Some of the other testing where we talk about the smooth pursuits and the saccades where you're going to targets, if people are having issues with those, the exercises just change based on the presentation. So there's not really a cookie cutter approach where you can say, you know, you're having visual problems, here are your 5 exercises that'll help. It kind of depends more on the individual person's presentation. When it comes to treating balance issues, again, it kind of comes back to that sort of little diagram on the top right there. You know, really where is the weakest link in their balance system? Is it more of a visual thing that needs to be addressed? Are they having an inner ear disorder? Is there something going on with their neck, which we'll kind of talk about? And then more often than not, it's more processing that information within the brain. There's a movement detectors when our neck is at rest, we're getting some feedback from them. And then when we turn or look up or tip, whatever the motion might be, just like with those inner ear organs, we also get information from our neck about that stuff. If you have an alignment issue in your neck where things are off just by a little bit, or if you have a lot of tension on one side but then not on the other side there, that difference, the discrepancy, the asymmetry with that kind of information, when it goes up toward the brain, sometimes it gets a little bit confusing. So if my visual function is working great, I'm getting really good visual feedback, my inner ears are working really well, my brain has no trouble with processing of that information. However, my neck is sending in this sort of distorted or aberrant or not quite correct information. That's enough to confuse the system and result in issues with your balance or with dizziness. So again, these messages from the neck don't really match the incoming information from other systems. This results in dizziness, which is generally described as less intense than that crystal ear true vertigo, oh my gosh, the room's spinning for 30 seconds. It's not that severe. It's usually sometimes described as lightheadedness at rest, or more spinning inside of my head, or the room isn't moving when I get dizzy, but I'm kind of moving like this. It's those more vague descriptors, generalized just sensation of being off. It's not the severe, heavily pronounced type symptoms, for the most part. Sometimes when we do test people with that Dix-Hallpike test or Hallpike-Dix test for that crystal in the ear issue, that test requires a fair amount of rotation, probably about 60% of what most people have, and then almost half of how much extension they have, and then you lay them off the edge of the table. So that puts a lot of pressure and force into their neck. If they are already having a little bit of an issue there with weird feedback coming from their neck at rest, and then you put them in that vulnerable position, that stimulus or that drive can be enough to actually make your eyes move the same way that those crystals do. So we get people that are referred to us sometimes who either they've been told they have the crystal ear problem, or their neighbor had it and their symptoms felt similar, so they're assuming that they have it. And we lay them back and their eyes do move, but they don't move the same way that they move when it is that crystal in the ear issue, the BPPB. So you can see nystagmus or abnormal eye movements at times when your neck is actually contributing to this. So again, this idea of a joint misalignment. So this right here, this is actually the base of your skull, this picture. This is your first cervical vertebrae here and here. This is the second one. If you're looking from behind this person, that vertebrae is actually tipped a little bit to the right side. So their head might be looking right at you. Their eyes and their inner ear organs are saying, I'm looking straight forward, but their neck is saying, no, I'm not, I'm turned to the right now. So that's that discrepancy where you've got some system saying one thing, and then another system saying something else that will create that disequilibrium or dizziness. It's a little bit more complicated. It's not usually just turned. The way those joints move is sort of at different angles depending on what level you're at. But this is sort of a simplified schematic. Again, same thing with abnormal muscle tone. So you got a muscle kind of in the front of the neck. It runs from the base of the ear down toward your collarbone and your ribs. That muscle has the most of those position sensors out of any of the muscles within your neck. And then same thing with some of these tiny muscles that attach from the base of your skull to the first two vertebrae down here. Those muscles have a lot of those end organs, those little position receptors or proprioceptors within them. So if there's issues or asymmetries or incongruencies there, that can create those same kinds of symptoms. But how do we treat it? One of the easiest ways to have an impact very quickly is adjusting someone's posture. So I'll have someone come in and they say, oh my gosh, my headache's like an 8 and I'm so dizzy right now. First thing is I do, and I sit them in a chair, I put their chin back and their shoulders up and back a little bit, and I'll say, well, how does that feel? I say, well, my headache's a little bit better than it was before. Maybe instead of starting with them at an 8 for that day, we get to start from a 5 instead. It may not go away, but that kind of adjustment can have at least some impact. The problem with individuals who have had concussion, they may have a headache, they're dizzy. When your head hurts, you kind of want to get down here. When you're dizzy, you just sort of end up drifting into this more protected posture. The problem with this is now you're putting all this force at the top part of your neck. These muscles here in your shoulders are all scrunched. And if you continue to have these symptoms, you've had headaches for 3 months, and you've been dizzy, and you've been spending a lot of time like this, all of a sudden, those things forget how to relax. Now you're sort of stuck here, and that takes a lot of training to undo some of those imbalances that have been caused over time. So we start with more of the posture stuff. Then there are many different manual techniques that can be done depending on the issue. If it's more of a muscle tension problem in the front or in the back of the neck, the techniques just change depending on what you're presenting with. And same thing if it's a little bit of one of those alignment issues like we talked about in the previous slide where you can shift a little bit. There are some very non-aggressive techniques that you can do to help promote a more neutral alignment. And then from there, it's all about exercise. So you get somebody where they want them, you get them in a nice postural position, you get their neck lined up nice and straight, and then you exercise the heck out of them so that the muscles that are meant for stabilizing can do just that. They hold things in place so that when they leave the office and they check their mirrors, things don't just revert right back to where they were. So you need that exercise component for sure to help keep things more in check and then start to undo some of those muscle imbalances that happen over time. The biggest being these upper trap muscles right here. They tend to be very, very tight, and then the muscles that sort of supplement or oppose them more in the middle and lower part of your back become actually inhibited because of how hard those upper trap muscles are working. They need to work on kind of shutting those down and getting stronger from muscles more at the base of your neck and a little bit lower down to help with the stability. Then as you progress with some of those things, you incorporate the core of the whole body. You can't just focus on that area because people aren't just in one static position all the time, so you need to create stability for all kinds of different dynamic movements. And then once you get everything kind of straightened out and they're getting better feedback from their neck, then you start working back through some different balance exercises so they can use this new and improved accurate neck information along with what they were already getting from what might have been pretty good with their vision and their inner ear organs to sort of further strengthen the entire system. So headaches, I'm just going to touch on a little bit. So headaches, after concussion, you can experience different kinds of headaches. So that's a lot of times in this case where somebody who's either a neurologist or a sports medicine physician, one of the first things they're trying to decide is really where are these headaches coming from. Really what we see the most of are the cervicogenic or tension headaches. So that's kind of the stuff that's driven from the neck. You've got tight muscles, you've got a little alignment problem, you've got something that is creating a noxious or painful stimuli that gives you a headache. You can have what's called a post-traumatic migraine. So that is related more to the neurotransmitter and chemical balance within the brain resulting from the trauma that is actually in the brain, and that's what's causing the headache. This is that hypersensitivity. This is something where if somebody is only experiencing this true post-traumatic migraine, they may not get better without being medically managed, so taking medicine also to help calm that down, so then they can get through what we need to do in therapy. This idea of an exertional headache, so this is where people move, they may be getting up from a chair or getting out of bed, and that creates a headache that just has to do with the way that pressure is regulated within the brain, and the ability to regulate that kind of stuff is often disrupted after concussion. It's more that automatic or autonomic nervous system function that handles those things for us, and if there's some disruption there, you can get headaches as a result. Another huge one is rebound headaches. So if someone's been having headaches, they're taking ibuprofen 3 times a day for 2 weeks or 3 months or whatever it might be. That can actually create more headaches as a result. So it's more of a medication overuse. So again, most of those are more managed on the medical end. We can do some things for more of the exertional headaches, but again, our bread and butter is sort of more that cervicogenic or tension type headache. They also have something that's sort of called a transformational migraine, where you start out with more of a tension or cervical headache, but then you had it for so long that kind of becomes hardwired, and then your brain starts to almost experience it more like a true migraine kind of sensation phenomenon. So differentiating from a cervical versus a migraine headache, so the tension type things, you've got more pressure, tight, vice. It's generally not, oh my gosh, it's sharp and stabbing. You generally don't have the same nausea or other related symptoms. The light and sound sensitivity is not like it is when someone's having a true migraine, when it is more coming from your neck. The other thing with more of a tension or cervical headache is neck pain or going down into the shoulders. So those are the kinds of things that people will tell you when it's more of a cervical headache compared to more of a true migraine. So just a Venn diagram for you guys. So again, differentiating kind of the type, and then there is some overlap. You can have either a cervical headache or more of a migraine on one or both sides, or again around the eyes, whereas the cervical headaches a lot of times are more localized posteriorly toward the back. I just put these pictures on there to kind of show how complicated that area is back there in the back of the head and the neck. So the big one on the left, you can see where all these little muscles are attaching to those top vertebrae in your neck. You've got nerves that are passing around in through there. So you need the alignment of those vertebrae to be intact. You need those muscles not to be too tight, pulling things out of whack or putting pressure on things, or being just sore themselves, or also not compressing on those nerves down here on the bottom right. You can see that they travel up the back of the head. If either the nerve is irritated or things are pressing on the nerve, that will send more headache pain, generally up the back, almost over the top of the head. That's where some of the nerve block treatments come in. Give a nerve block to that area. It calms it down so that you can work on the things around it without overstimulating that nerve there. And then same thing with some of the trigger point things. That gives you a chance to have things relaxed enough to move forward in other areas. This is my 30-second soapbox on posture and text neck. So as our posture drifts more and more forward, the weight of our actual head on our neck increases. And then when we're in the more of those forward positions or far from neutral for a long time, that actually changes the way that other muscles that surround that area function. So the further forward you go, the tighter those upper muscles get in the back. The weaker those lower down muscles in the back get. The tighter certain muscles in your chest get, and then the weaker certain muscles in the front of your neck get. So it ends up being this kind of cross pattern of weakness and weakness and tightness kind of opposing each other, which makes things that much harder to undo. So just going through a PT evaluation, it all starts with the history. So the first day someone comes to see us, we ask many questions about the specifics of their symptoms, not just do you have headaches, yes or no, or are you dizzy, yes or no. Vision testing, going through the more individualized vestibular testing, different inner ear functions, looking at many different types of balance, so while you're standing still, while you're moving, when your eyes are open, when you're closed, when your head has to move, different positional tests. If someone is more acute or they haven't seen a neurologist or somebody experienced with a concussion, we'll screen out more serious central nervous system problems just to make sure that there's not some sort of red flag thing leaking through. Looking at the neck and palpating, looking for more of those tension and alignment issues, and then some different outcome measures that are either scored or timed, so we have an idea of where we're at now, and then we can measure progress. And then we treat from there. So you need to change people's activities, sort of educate them on why they're having these symptoms, what things they may be doing currently are making them worse and they need to stop doing, or what things they can do to help improve right from the beginning, and then going through more of the vestibular, the balance, and the cervical stuff. And as you're getting closer to getting better, you got to push them a little bit. And last thing, we do know that of some things that will predict someone having a harder time recovering. So if someone is telling me certain pieces about their history, like they have a history of migraines, or they have a history of learning difficulties before their injury, I already know that they may have more issues with the ability to be in the classroom and be an effective student, and they may have more headaches and migraines as a result. A little bit more slow to recover are some of the younger kids, mostly because their brains are still forming at such an intense rate, whereas by later in adolescence, things are a little bit more finalized and they have a little bit less disruption. The sensation of fogginess is a symptom where when you hear that, that is one of the last symptoms to improve. This idea of the post-traumatic migraine, that is something that will not allow things to progress as quickly as you might like. And again, this is something that Dr. Zhang had mentioned at the last meeting. The #1 predictor of somebody having symptoms longer than 30 days is the immediate onset of dizziness right after their injury. Another thing I found interesting is the brief loss of consciousness. So if you lose consciousness for less than 30 seconds, that's not really indicative of your long-term outcome, whereas a longer loss of consciousness might be. But a brief one, people think, well, I was knocked out for 20 seconds, this is going to take forever to get better, I lost consciousness. That's not really the case.
With people who have sensitive necks, backs, and shoulders.
Okay. The exercise, actually, we first start with mobility because a lot of the muscle structure becomes very hypertonic. The muscles become shortened chronically. The patients tend to develop what are called like trigger points and knots in the muscles. From the brain utilizing those muscles is a protective measure. So we start with mobility and we start with elasticity of the muscles, and then as the patient is on their recovery and they're able to control their symptoms a bit more with the headaches and the dizziness and the imbalance and any of the post-concussive syndrome that they're dealing with the central nervous system. Then we transition them more to like an active role with physical therapy techniques and strengthening, and it's mostly done around the rib cage to the neck and the upper back.
Muscles do you tend to work on for patients who suffered a concussion?
Most concussed patients tend to have hypertonicity. Why don't you just turn towards the camera? Between the entire back of the head, neck, some of the facial muscles, we check the jaw, the long muscles of the back and neck, especially the trapezius area, the levator area, and the parascapular area. And it tends to stop about the mid-back down in this area because that's where the sclerotidia is for muscle girding.
What does seeing a chiropractor do to help a patient who has suffered a concussion and might have a really tense neck and head?
Well, concussions tend to cause hypersensitivities in the central nervous system. So seeing a chiropractor, as long as the patient's tolerating treatment appropriately, we help with restoring range of motion, reducing hypertonicity in the muscular structure, aligning the spine, getting intersegmental or between the joint segments back and free, and this can help with headache. It can help with some of the secondary symptoms of the concussion, balance, headaches, and we tend to help transition that person into a physical therapy role so that they can get active in their care to restore strength and core strength and full mobility around the spine.
How do you work with a concussion patient if they are extremely sensitive to movement and touch?
Well, most concussion patients are extremely sensitive to movement and touch just because of the nature of the injury to the central nervous system. So, you know, with time and experience, you become really aware to communicate effectively with that person on exactly what they're tolerating with touch, with depth of touch, with depth of movement, and around the spine and the muscle structure. So I think that's based on the chiropractic technique that you're applying, and also just your experience level as a practitioner.
And what type of exercises do you do with people who have sensitive necks and backs and shoulders?
Okay. The exercise, actually, we first start with mobility because a lot of the muscle structure becomes very hypertonic. The muscles become shortened chronically. The patients tend to develop what are called like trigger points and knots in the muscles from the brain utilizing those muscles as a protective measure. So we start with mobility and we start with elasticity of the muscles, and then as the patient is on their recovery and they're able to control their symptoms a bit more with the headaches and with the dizziness and the imbalance and any of the post-concussive syndrome that they're dealing with the central nervous system. Then we transition them more into like an active role with physical therapy techniques and strengthening, and it's mostly done around the rib cage to the neck and the upper back structure to the neck.
Thank you.
All right, it's ready.
How can you determine if someone has a concussion?
A lot of it is based on the symptoms. If you get a good history about what happened with a particular injury, or whether it was more of a whiplash injury, whether there was true impact during an injury. But a lot of it is based on the symptoms that people experience directly after the injury. The definition of a concussion is there has to be some transient neurologic deficit or an issue. So I had and felt like I had got my development wrong, or I felt really unstable, or I didn't know what direction I was going in. If I'm playing a football game, I'm looking at it thinking my headache doesn't have to be the whole thing. It has to be a little bit more to it.
What is the risk to keep playing after you sustain a concussion? Like to go back onto the field, keep playing instead of sitting out?
Biggest thing we worry about is impact upon injury. So if you're not yet healed from the first injury you sustained, your brain isn't healed, you go back and get the other one. It's called double impact syndrome or second impact syndrome, but very rare to actually have a true second impact syndrome, which is devastating. Usually, typically, there's very large, severe traumatic brain injury. More commonly, we see that there is multiple sub-injuries, so they call them sub-concussions. So if you are in a football game, for example, and you get hit and you get a concussion and you're disoriented, and I always tell people it's almost like being drunk, not that you know, but it doesn't feel like the world is right, you feel foggy, and so you're not making good decisions. So to expect that individual can make a good decision for themselves is not always appropriate. So a coach or a parent or a friend should be able to intervene and say, listen, you don't look right. It's not bad to tattle on your teammate. It's actually the good friend thing to do, to tell someone, this person doesn't even know what inning we're in or what quarter we're in, or they're not making any sense. So by putting that out there, you can actually tell someone and prevent them from having a second injury. Now, say that person goes out and has a second injury within the same game, they're at a higher risk for prolonged symptoms. So injured people who have multiple head injuries within the same day or the same game, or multiple games in the same short time frame,
we see it takes them a longer time to recover. They typically have more symptoms, and the symptoms are more severe. So, and a lot of that has to do with the fact that a concussion itself is a metabolic condition. So it's a biochemical problem. So the brain gets jostled like an egg. If you shake an egg, the yolk inside the egg, you know, the white part is kind of like our cerebrospinal fluid in our head, but the yolk is kind of like the brain. If I shake an egg like that, the yolk will hit the sides of the eggshell, correct? The brain hits the sides, it has traumatic injury. There's shearing force on the neurons. The neurons then have difficulty with blood flow. So there's decreased blood flow to the brain, and that signals some trauma. And then there's bad chemicals that are released, and there's a cascade of chemicals where certain things are higher, like potassium, that we normally wouldn't see high in the brain, calcium that we wouldn't see high in the brain, and it actually causes damage. So until that damage is repaired and the blood flow is restored, someone's at risk for causing even more damage.
What is post-concussive syndrome?
It's basically what you experience after the concussion itself. So everyone has a different experience with it. You know, we always ask, this is Dr. McVeigh's 5 big questions. We ask about a specific array of symptoms. We ask about headaches, dizziness, sleep disturbance, attention, concentration difficulties, and mood issues. But everyone has a different experience. Everyone has different types of symptoms that go along with it. But it's what you experience after the injury can vary from person to person.
And the definition of it is different in the literature that you would read. So some people say that it has to be over a month that you would experience it. Some people say over 3 months. So somewhere between a month and 3 months of experiencing prolonged symptoms. You can't say that someone had a concussion and a week later they're still having symptoms. It's not post-concussive syndrome. So they have to have prolonged issues.
Is there any way to prevent a concussion from happening in the first place?
An excellent question. I think it depends on what is causing the concussion. So, for example, if you're in sports and you're in football, we have changed the rules, the way that people practice football now. So Pop Warner rules now say that kids are not allowed to tackle as much and have contact as much within practice, that should be reserved for the games. So people are trying to modify the way that we do a sport. For example, with football, you've seen now the new rules. They'll immediately pull someone out and do the concussion protocol when they see that someone has gotten hit. And then a doctor has to evaluate them. They have to go through a protocol with examining like the SCAT testing, which is a sideline concussion assessment, and decide if they can go.
Can multiple concussions increase the time of recovery for like a more recent concussion that you suffer if you have multiple concussions prior to that?
One of the things we're trying to look at right now with some of the research we're doing. But in theory, I think that's what we've seen mainly clinically in the office with our patients, is that the more concussions they have sustained, the longer it does take them to recover.
The studies have shown that the higher number of events that you have, the longer it takes if you get another injury. So usually in neurology, we say 3 strikes and you're out. So if you have 3 decent concussions, we usually tell you that you should avoid playing high contact sports from there on out. There's some leeway with that, and so sometimes if someone has had a very mild injury and then one decent injury and another decent injury, I might say, well, I wouldn't do high impact sports, but you can do a medium impact sport like a basketball or a baseball, as opposed to football and hockey and soccer, which are high impact sports. So it's a definitely we know that it increases your risk of prolonged recovery if you've had multiple injuries, but as far as what we advise people to do, it depends on in each individual case.
What does a neurologist do to help a concussion patient, and why should a patient who suffers from concussion see a neurologist?
That's a good question.
We do brains, so this is our thing. Basically, a concussion is a very complicated process. So it is not just the head injury, but the neck is involved, the back is involved, visual tracking can convergence problems when you look at things, they're tracking. So this is multiple neurologic processes that are going on, which is why it's so confusing and it's so hard to get people better, is it's not just headache. People really miss the boat when they think, okay, your headache's gone, get back on the ice. You know, that's the wrong thing to do. Sydney talked about the 5 things that I always ask about. You know, if your sleep is not right from having a concussion, you're going to have a headache. If your headache is there, sometimes it can make you moody. If you're moody, then a lot of times you can really be forgetful and not pay attention. And the headache alone can cause dizziness. So all of these things are interrelated. And so part of the neurologist's purview is to dissect that apart and treat each of those sleep disorders, headache problems, upper cervical problems in the neck. And so that's what we're trained to do. So it lends itself well to seeing a neurologist. Not that the other subspecialties aren't fabulous as well, but especially with headaches, you know, really can help tremendously.
Can you ever completely heal from a concussion or post-concussive syndrome?
I think so.
Absolutely. Absolutely. You can definitely heal. I think that it depends on the number of events, like you said, that you've had, the severity of the event. Ironically, we see that if the more severe events, like we've had patients that have had skull fractures and brain bleeds and have been in the ICU for days, they actually do better than people who have very mild injuries or multiple mild injuries. So the research has shown that, which really doesn't make much sense, right?
Yeah.
But what it comes down to, we believe, is because those neurons are swollen. Like I said, there's decreased blood flow, everything's swollen, there's bad chemicals that are released for the milder injuries. They tend to have a bigger toll on the whole brain, whereas the bleeds and the fractures are very focal, and so that heals much easier and things are a little bit better.
Thank you.
Thank you.